Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Welcome back. Today, we're going to deconstruct the pharmacology of anti-epileptic drugs. Our goal here isn't just memorization, it's about building a really solid conceptual framework that's going to serve you well in clinical practice and, of course, help you crush your exams. So, let's start at the very beginning. What is the problem we're actually trying to solve? Well, at its heart, epilepsy is a disorder of the brain's electrical system. It's a chronic condition where neurons, for some reason, start firing abnormally and way too much. And those attacks of abnormal electrical discharge, that's what we call a seizure.
Now, the anti-epileptic drug class is huge, and it can be pretty overwhelming to learn. So here's our strategy. We're going to master the entire class by doing a deep dive on one single, super high-yield prototype drug, phenytoin. If you can understand the core principles of how this one works, you'll be able to apply that knowledge to so many others.
All right, here's our game plan. We'll start with the problem itself, the pathophysiology of epilepsy. Then we'll meet our prototype, phenytoin. We'll break down its mechanism and uses, talk about its tricky pharmacokinetics, cover the adverse effects, and finally wrap up with those critical drug interactions and exam pearls you need to know.
Okay, let's dive into this first section. Because before we can really appreciate the solution, the drugs, we have to have a crystal clear understanding of the problem. We need to know the why behind the treatment.
At its core, you can think of epilepsy as an imbalance. It's like a scale in the brain. On one side, you've got your excitatory signals, mainly driven by the neurotransmitter glutamate. And on the other side, you've got your inhibitory, calming signals, mainly from GABA. In epilepsy, that scale gets tipped way over to the excitatory side, either too much glutamate or not enough GABA. Couple that with neuronal membranes that are just a little too eager to let positive ions like sodium and calcium rush in, and you've created a state of hyperexcitability, a brain that's basically primed to have a seizure.
Okay, so with that picture of an overexcited brain in mind, let's bring in our prototype drug, phenytoin. This medication is an absolute cornerstone of anti-epileptic therapy, and really, truly understanding it is the key to mastering this entire area of pharmacology.
So, why do we focus on phenytoin? Well, it's the classic prototype for a reason. Its mechanism and its clinical use profile are fundamental concepts that show up everywhere. It represents a whole class of drugs that work by targeting voltage-gated sodium channels, and clinically, you'll see it as a first-line choice for two really common types of seizures, partial seizures and generalized tonic-clonic seizures, which you might also know by their older name, grand mal seizures.
So this is where it gets really interesting. We have to connect the dots. How does this drug's action at a tiny molecular level actually translate into stopping something as dramatic as a seizure? We have to link that mechanism directly to the therapeutic effect.
Okay, this is the really cool part. Think about a seizure. It's all about neurons firing at a ridiculously high frequency. Phenytoin is smart. It works by binding to those voltage-gated sodium channels and essentially locking them in their inactive state for a little bit longer. Now, here's the key. Channels on neurons that are firing like crazy spend more time in that inactive state, which makes them the perfect target for the drug. We call this use dependence. It means phenytoin is way better at stopping the pathological high-frequency firing of a seizure than it is at messing with normal, everyday brain activity. It calms the storm without shutting down the whole city.
And this table does a great job of showing exactly where phenytoin fits in. You can see it right there, first line for partial and grand mal seizures. And this is a classic must-know exam pearl, look at what it's not used for. Phenytoin can actually make petit mal or absence seizures worse. That's a critical distinction you have to remember.
All right, so we know what it does and where it works. Now we have to talk about how the body handles this drug. And let me tell you, the pharmacokinetics of phenytoin, its journey through the body, are famously complicated and can be a real headache in the clinic.
This slide is absolutely critical, both for patient safety and for your exams. Trying to predict the blood level of phenytoin is just incredibly difficult. For one, its absorption can be all over the place. But the real kicker is that it follows what we call saturation kinetics, or zero-order kinetics. Basically, the liver enzymes that break it down get overwhelmed really easily. This means a tiny little increase in the dose can cause a huge, disproportionate, and potentially toxic jump in the drug level. On top of that, it's super sensitive to other drugs that can induce or inhibit those enzymes, and it can even get knocked off its binding proteins in the blood by other drugs like aspirin. It's a recipe for unpredictability.
Okay, let's switch gears and talk about the downsides. We need to cover the adverse effects, which, for phenytoin, is an extremely high-yield topic. These are the common and serious watch-outs that you absolutely have to be aware of.
So these dose-related neurological side effects make perfect sense when you think about the drug's mechanism. It stabilizes neuronal membranes, right? While too much of a good thing can overstabilize them, leading to these CNS effects. Nystagmus, that involuntary, jerky eye movement, is often the very first sign of toxicity. As the drug level creeps up, that can progress to double vision, or diplopia, then problems with coordination, called ataxia, and just plain old drowsiness.
So this all leads us to a really important clinical question, one that gets at a specific set of side effects that have major implications for certain patients.
And here is your answer. These cosmetic side effects are often the exact reason this drug is avoided in younger patients, especially young women. It can cause gingival hyperplasia, which is a pretty significant overgrowth of the gums. It can also cause hirsutism, excess hair growth, and a general coarsening of facial features. Beyond that, it can also mess with folic acid and vitamin D metabolism, which can lead to problems like anemia and bone softening.
All right, let's bring it all home. We're going to consolidate the most important drug interactions and clinical pearls. This is where we put it all together into that high-yield information you need to walk away with.
A key takeaway here is that phenytoin is a potent cytochrome P450 enzyme inducer. What does that actually mean? It means it tells the liver's drug metabolizing machinery to speed up and work overtime. The result? It chews up other drugs, like the blood thinner warfarin, much faster than usual. The clinical consequence is that the levels and the effectiveness of those other drugs go down, which can be really dangerous. So to wrap it all up, if you're going to remember anything, let it be this. This is your high-yield cheat sheet. The mechanism? Sodium channel blockade. Indications? Partial and grand mal seizures. Contraindication? It makes petit mal seizures worse. Pharmacokinetics? Totally unpredictable due to saturation kinetics. Key side effects? Gingival hyperplasia and nystagmus. It's also teratogenic, meaning it can cause birth defects like a cleft lip or palate. And finally, it is a potent enzyme inducer. Burn these facts into your brain.
And this leaves us with one final thought to take with you into the clinic. You know, mastering a classic drug like phenytoin isn't just about memorizing facts for a test. It's about developing the clinical reasoning to weigh risks and benefits. Even though it's effective, its challenging profile means that everyday clinicians have to ask themselves, is this old workhorse still the best option, or should we be reaching for one of the newer, cleaner agents? And that's a question you'll be answering for the rest of your career.